Welcome to Part 2 lecture on clasp assemblies. We will continue our discussion on superbulge and infrabulge clasp and indirect retainers. We're going to talk about some basic principles of clasp design. Placement of direct retainers is favored on the facial side, but contours are not always present for that placement. Placement of retention on the lingual of a premolar is contraindicated because the length mesiodistally is compromised and the arm will be short and therefore will lack flexibility. Also, if an arm is placed on the lingual of a premolar, then the framework must dip down and may present a food trap. There's often not enough room to dip down and still have a strong major connector due to the depth of the functional floor of the mouth. The lingual retention is possible on molars because of their length, and it usually depends on the position of the undercuts. There is only one retentive arm placed on an abutment tooth. The opposite side of the tooth must have a reciprocal component. There's really only one exception to this rule, and it is associated with a prosthesis that we should not do as dentists, even though you're going to see them walk into your practice. A unilateral partial denture is sometimes made for only one side of the arch. If it is done, the retention must be placed on both sides of the tooth to prevent dislodgement. You only do these if you wish to take a high risk of being sued for a patient developing peritonitis because of swallowing the prosthesis and the prongs perforate the intestines, causing massive infection. If you want to sleep well at night, you do not use or do the unilateral partial denture. If a direct retainer is placed on the facial on one side of the arch, at least one of the direct retainer arms on the other side of the arch must be on the facial surface. If a direct retainer is placed on the lingual of the abutment on one side of the arch, there must be at least one retentive component on the lingual on the opposite side of the arch to satisfy balanced retention. The only situation that is not acceptable is facial retention on one side of the arch and lingual retention on the opposite side of the arch. This partial would have a tendency to dislodge itself in the direction of the arrow shown on the slide. Each retentive direct retainer should be opposed by a reciprocal component which resists orthodontic movement exerted by the retentive component. The reciprocal component can be an arm or plating if it's on the lingual. The reciprocal arm has three functions. One, it should provide reciprocation and stabilization opposing the retentive arm. Two, the reciprocal arm should be placed so that the denture is stabilized against horizontal movements, and the reciprocal clasp arm may act to a minor degree as an indirect retainer. Reciprocal components of the clasp assembly should be located at the junction of the gingival and middle third of the abutment crown. They must be above the survey line and they should touch the tooth prior to the direct retainer touching the tooth. This position will permit the abutment tooth to better resist horizontal and torquing forces better than if it were more occlusally located. The amount of retention should always be the minimum necessary to resist reasonable dislodging forces. Clasp retainers on the abutment teeth adjacent to the distal extension bases should be designed so that they avoid direct transmission of tipping and rotational forces to the abutment. We will discuss these design features when we talk about the Kennedy Class 1 and Class 2 rules of design. Some basics of design of the cast circumferential. Number one, it originates from the framework from an occlusal direction above the height of contour, and it gently slopes until the terminal 1/3 crosses the height of contour and goes into the 0.01 undercut. The reciprocal arm is above the survey line on the opposite side of the tooth. The retentive terminus of the clasp should be directed occlusally and never toward the gingiva. It should not look like it's a diving airplane ready to crash. It should follow the form of the marginal gingiva by sloping upward. The clasp arm should terminate at the line angle and not at the mid-facial area. The one on the lower is short. The terminal end of the direct retainer should be placed as apically as possible without impinging on the gingival margin. It should be in the gingival 1/3 of the crown and no higher than the middle 1/3 if absolutely necessary. When the design is for an extension base RPD, the cast circumferential should not be used in the following circumstances. A. To engage the mesiofacial of an abutment tooth next to a posterior edentulous area, and B. To engage a distal facial of an abutment next to an anterior edentulous area. We are going to begin to talk about our superbulge clasp. They are clasps that are predominantly used in the tooth-supported removable partial dentures because they do not accommodate for movement of the prosthesis. The first is the simple circlet cast circumferential clasp. It's very simple in design. It is the clasp of choice for the Kennedy Class 3 and 4 tooth-supported removable partial dentures because of its excellent retention and reciprocation. It adapts to the tooth closely, so it minimizes tooth entrapment as compared to the infrabulge clasp. There are some disadvantages of the cast circumferential, and they include, first, large amounts of tooth surface are contacted by the clasp arms, so oral hygiene is essential in order to minimize tooth decay. Secondly, they alter the tooth morphology, and care must be taken to place the arms where it does not affect food elimination or occlusion, because they increase the width of the tooth. Adjustments in the retention given by the cast circumferential may need to be made by moving the clasp terminus cervically into an angle of cervical convergence or occlusally into a lesser undercut. Cast Cs are not easily changed because they are half round in shape. True adjustment of the cast C clasp in an occlusal gingival direction is almost impossible. And lastly, more metal may be displayed by the cast circumferential than you would find with the bar clasp. The reverse circlet clasp is used when the undercut is on the distal line angle adjacent to the edentulous area. It originates from the mesial rest and gradually slopes downward to the undercut on the distal facial of the abutment tooth. The reciprocal component is on the opposite side of the tooth. In the Kennedy Class 1 and 2 cases, the mesial to distal projection of the reverse circlet helps to alleviate stress transmission to the abutment teeth. When the distal extension receives forces, the direct retainer actually moves into a deeper undercut, thus disengaging from the tooth. It is not the choice for canines or first premolars, as the mesial to distal arm is not very aesthetic when you see it from the anterior direction. The multiple circlet clasp is like having two opposing circumferential clasps that are joined together at the terminal ends of the two reciprocal arms. It is used when the principal abutment tooth is periodontally involved and you want the stresses distributed between multiple teeth. The Embrasure clasp consists of two rests, two reciprocal components, and two direct retainers joined at their body. The rest must traverse the marginal ridge and become the retentive arms and the reciprocal components. Sluiceways from the major connector to the buccal arms need to be prepared to provide bulk for strength of the clasp assembly. Fatigue and failure of this clasp is often attributed to inadequate preparation in these sluiceways. The ring clasp is indicated on the mandibular molar that has tipped into the area of the edentulous space. The molar often tips to the mesial and leans to the lingual. The ring clasp was developed to accommodate situations where tooth modifications were not performed or could not be performed on a tooth without mutilation of the tooth, often on that mesiolingual area. It is used when an undercut cannot be approached by other means. The undercuts are usually on the mesiofacial or the mesiolingual surfaces, which are next to the point of origin of the clasp from the minor connector. The ring clasp encircles the tooth about 320 degrees. The clasp should never be used as an unsupported ring as shown in the lower right picture without that distal rest. The text states that the ring clasp should always be used with a supporting strut on the non-retentive side, with or without the auxiliary occlusal rest on the opposite marginal ridge. It recommends an additional support provided from a bracing arm that originates from the minor connector, runs parallel to the gingival margin, and then ascends to the reciprocal component. It states that this strut aids in reciprocation and stability and is really not available unless the support is used. We have done several of these and do not always place that extra supporting strut and have not really had any problems with it. We do always place a mesial and distal rest on the ring clasp. The clasp shown is sometimes called a C-clasp, a reverse action clasp, or a hairpin. It is a simple circlet clasp where the direct retainer loops back to engage the undercut on the same surface from its origination. It allows engaging a proximal undercut surface from an occlusal direction. The superior portion of the direct retainer arm is above the survey line, and the lower portion crosses the survey line and engages a .01 undercut. The disadvantages of the reverse action or hairpin clasp are that it covers a large amount of surface area, therefore it becomes an oral hygiene problem. And because of this large surface area, it may not be very aesthetic on the patient. The flexibility of the clasp is really limited, even though it looks like it's very long and flexible, and the functional load is increased. The half and half clasp has a direct retainer that originates from one end of the abutment tooth, and the reciprocal component originates from the other end of the abutment tooth. McCracken's text indicates that there's really no use for this type of clasp in the bilateral extension-based partial. It was originally designed to provide dual retention in the unilateral partial dentary design, which is not recommended under any circumstances. The Onlay clasp is a rest that covers the entire occlusal surface and is waxed into occlusion with the opposing arch before being cast. Both casts are mounted on the articulator. It has extensive tooth coverage, therefore oral hygiene is absolutely critical on this type of a case. The direct retainers originate from the onlay rest, as you can see in the top photo. Now, for a case like this, crown and bridge should be considered to restore this mouth, as it would be a more ideal restoration, but this is the poor man's crown and bridge. The continuous clasp starts on one tooth and continues to the next tooth where it gets its retention. Please notice that the clasp or the direct retainer on the buckle of number 20 extends up to number 21 into the retentive area. It's very important that you have good reciprocation when you use something like this. The Wrought wire circumferential clasp is a wire that is circular in cross-section and is soldered to the framework some distance from the abutment tooth to keep it flexible. It can be cast to the framework, but this is not ideal, as the metal heats up and the flexibility is impaired. Because of the round shape, it flexes in all directions, which allows the clasp to flex in all planes. It therefore minimizes the transfer of harmful forces to the abutment tooth. Because of the improved flex, it can also be placed into a deeper undercut of .02 inch. It became popular when the combination clasp was introduced by Dr. O.C. Applegate in 1965. Name sound familiar? The wrought wire is often used in the Kennedy Class 1 and 2 designs to reduce stresses on the abutment teeth when the extension base depresses into the tissues. It also can be more aesthetic than the cast circumferential clasp. The disadvantages of the wrought wire clasp are: 1. Additional steps are required during laboratory fabrication of the framework, which adds up to additional expense. 2. To me, the most frustrating disadvantage is that it is susceptible to getting out of position and needs repeated adjustments. Patients should be encouraged to remove the prosthesis with their fingers under the base rather than using the clasp to remove the partial, but they don't. They forget, or for convenience sake, they just don't. The patient often gets his own pliers out and adjusts the partial. This can lead to all kinds of problems, including breakage. It does not work well for reciprocation and does not afford good stability. That is why the cast clasp or plating is used for reciprocation in conjunction with it as the direct retainer. This, in the nutshell, is the description of the combination clasp. Here is pictured the combination clasp. It consists of two types of clasping mechanisms. One is the cast circumferential clasp for reciprocation and the wrought wire clasp for the direct retainer or retention. If there is not enough room to dip down on the lingual and avoid the marginal gingiva by 3 millimeters and still have a lingual bar in that area that is at least 5 millimeters in width, then the lingual plate is used for reciprocation. Let's look at the infra bulge clasp. The infra bulge clasp approaches the undercut from an apical direction. They exhibit a push type of retention as compared to the super bulge clasp that have a pull. The retention of the infra bulge clasp is controlled by the length and the taper of the approach arm. They determine the flexibility. The greater the length and taper, the more flexible the clasp. Because the clasp approaches the undercut from an apical direction, it can be a lot more aesthetic than the super bulge clasp like our cast circumferentials. There are a variety of bar-type clasps available, and they usually are named for their shape. We will discuss the T-bar, modified T, the Y, and the I-bar. We will be using the I-bar and the modified T-bar predominantly in our clinic areas. The approach arm of the infrabulge clasp must not impinge on the soft tissues adjacent to the abutment. Our text does not advocate the placement of relief wax to create a slight space under the approach arm of the bar clasp. McCracken's text shows that relief. We have had less problems with bars digging into the tissues during function when we have that thin layer of relief wax placed below the approach arm. Use of custom trays, viscosity of impression material, and type of impression technique used all affect whether there is a need for this relief. The custom tray with a viscous impression material may place pressure on the tissues so that the master cast reflects that pressure. The framework may come back with a framework appearing to have a space on the cast, but in the mouth it is placing pressure on the tissues and no room for acrylic under it. So we have used the relief. Basic rule number 2 is that the approach arm should be designed so that it crosses the free marginal gingiva perpendicular to it. You don't want it to come off from the side. The approach arm should not be designed to cross or bridge a tissue undercut. It will become a food trap and could cause irritation to the soft tissues. If this occurs, the patient will be very unhappy with the prosthesis. This bar shown on the lower picture was returned by the lab. Where the error started is not known. Orientation of the cast on the surveyor or too much relief, but the space under that approach arm would cause 2 problems. 1, the clasp approach arm would be a terrible food trap, but even more disconcerting would be the chronic irritation caused to the inside of the lower lip mucosa. This was a remake. The approach arm should be uniformly tapered from its origin to its terminus. This is shown in this particular example. The clasp terminus should be positioned as far apical as possible without impingement upon the gingival margin. The closer it is to the gingiva, the less leverage upon the tooth. The minor connector that connects the rest to the framework must be rigid enough in order to enhance bracing or reciprocation for the prosthesis. Rule number 7, the approach arm parallels the ridge and avoids the marginal gingiva by 4 millimeters. The arm is a minimum of 2 millimeters. Therefore, you need 6 millimeters of space between the marginal gingiva and the depth of the vestibule. There are some contraindications to the use of the bar clasp. First of all, if you have a shallow functional vestibule, including a functional frenum attachment, you have to look at that. That may negate use of the bar. If you have tissue or bony undercuts that the bar must traverse, then that would contraindicate it because the area would trap food and possibly irritate the gingiva. If you have a bulbous tooth, then you have a severe undercut, and that may negate the use of the bar. If you have an excessive labial or lingual tilt of the abutment, and finally, if you don't have an appropriate undercut in the cervical third of the tooth, you cannot use the bar. Let's discuss some of these bar designs. The T-bar gets its name from the shape of the bar, where the retentive clasp arm joins the vertical aspect of the approach arm. It originates from a component in the edentulous area, such as the base attachment, and runs parallel to the crest of the ridge, avoiding the marginal gingiva by at least 4 millimeters. The approach arm then turns upward at a rounded 90-degree angle. It crosses the marginal gingiva, ascends to contact the tooth at or above the survey line, or the height of contour. It has two horizontal projections that give the T shape. The one extends towards the edentulous area and crosses the height of contour to terminate into the .01 undercut. The other part of the T projects away from the edentulous area and stays above the height of contour to provide stabilization for the clasp assembly. This T-bar is indicated in extension base cases with the undercut in the distal buccal surface of the abutment tooth, and for tooth-supported cases adjacent to the edentulous area. It is contraindicated for mesiobuccal undercuts, as this would place detrimental torque forces on the tooth. Here's how the T-bar functions. On function, an occlusal load is applied to the extension base. The rest is the center of rotation when this force is applied. The horizontal part of the T closest to the edentulous area moves apically and slightly mesial. The arm disengages the tooth, which minimizes torque forces on the abutment, and the mesial force is countered by the tooth anterior to the abutment tooth. The T-bar offers aesthetic advantages to the cast circumferential when it's located in the cervical third. There's no shoulder present, as with the circumferential clasp arm. This is also an advantage because of possible occlusal interferences with the shoulder area of the cast circumferential clasp. A disadvantage is that there's a greater tendency to collect debris in the area where the bar stands away from the tooth and tissue. This can lead to decalcification of the tooth or inflammation of the tissue. This is why the bar is contraindicated when the undercut is high on the tooth, as in the bulbous tooth or the labially inclined tooth. All of the contraindications for the bar clasp apply to the T-bar. The modified T-bar we will use is associated with Henderson, Steffel, and McCracken, circa 1960. This direct retainer arm is designed the same way as the T-bar clasp, with the horizontal extension that goes forward being left off. It has a mesial rest on the abutment tooth next to the edentulous area, and a distal rest on the tooth anterior to it, in other words, an embrasure rest. Note that this is different from the T-bar that we just presented with a distal rest. There is a distal guide plate, and the lingual drops away, avoiding the marginal gingiva by at least 3 millimeters, with the guide plate and the minor connector leading to the mesial rest providing reciprocation. The combination of the two must satisfy the rule of encirclement, providing 3 widely spaced areas of contact of metal to the tooth. The modified T is used when we have a .01 retention on the distal facial surface of the tooth and when the bar clasp is not contraindicated. The guide plate extends to the lingual to where the tooth becomes a little bit narrower in order to trap the tooth from moving lingually when the direct retainer drops into the undercut. If there's insufficient room for the framework to drop down, it is then used with a reciprocal component that's placed at the height of contour. It is one of the 4 clasps for use on the distal extension removable partial denture design. Here's an image showing the specifications of the modified T-bar. Many of these specifications are similar to the I-bar in the approach arm area. The horizontal part of the bar originates from a strut of the base retention or from the metal base. It progresses toward the tooth horizontal to the crest of the ridge. It makes a rounded right angle at the mesiodistal height of contour of the tooth and crosses perpendicular to the marginal gingiva. It first touches the tooth at or above the height of contour. The retentive tip then crosses the height of contour into the 0.01 undercut in the terminal 1/3 of the tooth. This slide provides 3 views of the modified T-bar clasp. In the occlusal view, you can see how the distal guide plate extends to the lingual, where the tooth becomes slightly narrower in order to, in conjunction with that minor connector of the rest, trap the tooth from moving lingually when the direct retainer flexes into the undercut. The facial view shows the first contact of the modified T that is at or above the survey line, and the retentive tip crosses over the height of contour into a 0.01 undercut in the cervical third. The view of the lingual shows how reciprocation works, and one advantage of this form of reciprocation is that there's less metal contact because the arm has been admitted. The approach arm should be in the middle of the tooth, and the picture on the upper right shows that it is far too mesial on that surface of the tooth. This will provide unwanted forces on the tooth during function. The Y-bar is similar to the T-bar. The approach arm touches the tooth in the cervical 1/3, just above the height of contour, and the retentive and reciprocal components are nearer to the incisal edge. Only one of the projections of the Y is in the distal 0.01 undercut, but that happens to be very close to the incisal area. The reciprocal part of the Y-bar is all above the survey line, or the height of contour. We can sometimes alter the tooth to create an indication for a T-bar, which would be more aesthetic for the patient. Sometimes it's really hard to tell whether the clasp is a T or Y because they're very close to one another as far as appearance. Clasp assemblies can be designed to accommodate functional movement and minimize the Class 1 lever found in extension-based partials. The combination clasp and the RPI accommodate for functional movement. The combination clasp does this by having a more flexible direct retainer arm. The RPI does it by other means. We will discuss the RPI system, which is what we will use on our Kennedy and Class 1 and 2 designs unless the I-bar is contraindicated. Variations in philosophy of the RPI design exist. They're centered around the following factors. 1, the location of the rest. 2, the design of the proximal plate. And 3, the location of the retentive arm. For instance, there are 3 different philosophies as to how much surface area the distal guide plate should contact. Placement of a rest on the mesial changes the fulcrum and creates a Class 2 lever, which decreases stress on the abutment tooth. We're going to use the Kroll method of design of this clasp. If you want to get into this further, there's a full discussion in the McCracken's Removable Partial Prosthodontics 11th edition under direct retainers. The 4 components of the RPI clasping system are 1, the mesial rest, 2, a distal proximal plate, 3, an I-bar, and 4, you drop down on the lingual between the distal proximal plate and the mesial rest. Reciprocation is provided by the minor connector leading up to the rest and the distal guide plate. The specifications of the I-bar are as follows. It originates from the edentulous base attachment, and it usually originates from one of the cross struts of the base attachment to enable good casting of the metal. If meshwork is used, It usually originates at least one tooth width posterior to the natural tooth. The important thing to remember is that its length and dimensional thickness are two factors that affect flexibility of the eye-bar clasp. It tapers from its origin in base attachment and becomes horizontal to the ridge and is about 2 millimeters in width or thickness when it emerges from the base material. It should cross the marginal gingiva at a rounded right angle and touch the tooth at the .01 undercut. It extends upward in contact with the tooth to the survey line. The dimensions of the little pod that touches the tooth is that it's approximately 1.5 to 2 millimeters in width and 2 to 3 millimeters in height from that .01 undercut to the survey line. The apical position of the pod is at the .01 undercut. The superior border of the bar approach arm should be no closer than 3 to 4 millimeters from the marginal gingiva where it's running parallel to the ridge, and therefore the lower border of the approach arm is about 6 millimeters from the marginal gingiva. This illustrates that the guiding plane is prepared through an area of 2 to 3 millimeters from the marginal ridge apically. The guiding plate is then placed 1 millimeter above the bottom of the guide plane you prepared and touches the tooth through at least 1 millimeter in height. The laboratory will prepare the cast to provide at least a 4 millimeter opening at the apical portion of the guide plate. This space allows for food and debris to escape and not be jammed into the sulcus. This space also allows the partial to depress under masticatory forces, and the guide plate then rotates toward the tooth but does not torque the tooth. The framework rotates around the mesial rest toward the long axis of the tooth, and the eye bar actually disengages the tooth. Therefore, you do not get torquing forces on this abutment, or very little. This is the whole idea of the eye bar concept. A view from the lingual aspect of the RPI clasp reveals the mechanism of reciprocation for the clasp assembly. The guide plate must extend lingually past the buccolingual height of contour on the distal surface of the tooth. It will then trap the tooth from moving lingually when the direct retainer flexes into the undercut. The minor connector leading to the rest also aids in this reciprocation function. This is an occlusal view showing that the guide plate must wrap to the lingual to where the tooth becomes a little narrower mesiodistally. The guide plate then, in conjunction with the minor connector leading to the rest, traps the tooth from moving lingually when the eye bar flexes into the undercut. The RPA clasping system is a modification of the RPI. It may be used when the bar-type clasp is contraindicated. An example would be presence of tissue undercuts or lack of vestibular depth for the bar due to shallow vestibule or the presence of functional frenum that interfere with the placement of the bar. It is used when the undercut is located in the gingival 1/3 of the abutment tooth away from the extension base area. The Akers or cast circumferential clasp is placed as the retentive component. The combination clasp is preferred for use on the terminal abutments when torquing and tipping are possible because of the flexibility of the arm over the cast clasp. The wrought wire requires a .02 undercut, and that may be the determining factor for use of the RPA over the combination clasp. McCracken's text lists 5 types of extracoronal direct retainers that may be used on extension-based RPD designs. They are the RPI, the wrought wire, the modified T, the interproximal ring or circlet, and the hairpin clasp. All of these clasps may be used with the mesial embrasure rest with the minor connector leading up to it, and the distal guide plate that extends to the lingual to aid in reciprocation. This design eliminates the need for the lingual clasp arm. It places the fulcrum anteriorly to make better use of the residual ridge for support and provides stabilization against horizontal rotation of the denture base. The indirect retainer is that unit of the partial denture that assists the direct retainer in such a manner as to resist rotation of that extension base in an occlusal direction. The two rests on 22 and 28 are the indirect retainers. In order to qualify as an indirect retainer, the rest must be placed in a prepared surface called a rest seat that allows for a positive occlusal support for the indirect retainer. It can't just lean against an inclined plane. They must be anterior to the fulcrum line to prevent that rotation from taking place. The Kennedy Class 3 and 4 generally do not need indirect retainers because there's a clasp assembly that holds the partial in position at each end of the edentulous area. On the Kennedy Class 1, there are two extension base areas, and on the Kennedy Class 2, there is one, where no teeth are located posterior to the edentulous area, so there's no clasp assembly to prevent movement. Look at the lower right picture. It's a Kennedy Class 2 with one extension base area. A fulcrum line exists that is drawn through the two most posterior teeth, shown in red. The partial denture wants to rotate around this line when a load is subjected to the denture teeth that will be placed in that extension base area. That end of the partial wants to move in a downward direction when a load is applied to it. That movement is resisted by the clasp assemblies that are anterior to it and the residual ridge below it. When a sticky food is encountered, that area wants to lift up, and the partial wants to rotate around the fulcrum line. That rotation is resisted by the presence of a positive rest on the mesial of tooth number 21. That is the indirect retainer. It prevents rotation. It is usually found by drawing a perpendicular to the fulcrum line and is located as far as possible away from the fulcrum line. There are factors influencing the effectiveness of indirect retainers. 1. The principal occlusal rest on the primary abutments must be held in their seats by retentive arms. If they're held in place properly, then rotation can't take place. 2 is the distance from the fulcrum line. The following three things have to be considered: the length of the distal extension area, the location of the fulcrum line, and how far beyond the fulcrum line the indirect retainers are placed. 3. The rigidity of the connectors supporting the indirect retainers. They must be rigid to properly function. And lastly, the effectiveness of the supporting tooth area. If the indirect retainer is not placed in a positive rest state, it will not be effective. There are some auxiliary functions that an indirect retainer is used for. It reduces the anterior-posterior tilting or leverage on the principal abutments. The contact of the minor connector with the axial tooth surface aids in stabilization of the prosthesis. The anterior teeth are stabilized against lingual movement. It also may act as an auxiliary rest to support a long major connector, and it provides first visual indication that a reline may need to be done on the partial. Here are some sample arches of the various Kennedy classifications and their fulcrum lines. The indirect retainers are located in a position as far away from the fulcrum line as possible. This can be determined by drawing a perpendicular to the fulcrum line and selecting the best tooth or teeth on which to place the indirect retainer. The Kennedy Class 1 usually has two indirect retainers, but depending on the position of the fulcrum line, it can have one, as shown in the top picture number 2. The Class 2 usually has one indirect retainer. It might be a rest associated with an existing direct retainer as seen in the upper picture 4. The Kennedy Class 3 usually does not need to have indirect retainers, as it is clasped at each end of the edentulous area. The Class 4 usually doesn't need indirect retainers, but it may need them if a reverse extension base is created by a large edentulous area in the anterior. The rest that would be placed in the posterior act as indirect retainers, preventing rotation when that anterior area tries to lift up and rotate around the fulcrum line. The indirect retainer is an auxiliary rest placed on the occlusal, cingulum, or incisal area of a tooth. It is placed in a properly prepared rest seat, its purpose being to prevent rotation of the prosthesis. Here are three forms an indirect retainer may take. The lingual plate, or continuous bar, is not an indirect retainer, as it is placed on the lingual inclines of the teeth. They may aid in indirect retention by extending the effectiveness of the rest at each end, but they are not indirect retainers by definition. Suggested readings for the materials covered in this lecture are listed below. There's a lot of good information in them that just doesn't fit into a few-minute lecture. This is the conclusion of the Clasp Assemblies Part 2 discussion. For a natural progression of your RPD 1 course, please proceed to the lecture on denture bases and tooth replacement options. Have a great day.